I'm Tammy Frank with the Nebraska Medical Association. I'd like to welcome you to the fifth in the series of Foster Healthy Weight and Youth webinars that will focus on surgical treatment for obesity for children and adolescents. I'd first like to thank Dr. Carla Lester with Teach a Kid to Fish and the Animated Childhood Obesity Prevention Project, Holly Damon with the Department of Health and Human Services, Nutrition and Physical Activity for Health Program, Dr. Christina Fernandez with Creighton University Children's Physicians, Dr. Sally O'Neill, Jeff Klein, and the staff at Creighton University CME, and Dr. Corey McBride with the University of Nebraska Medical Center for all the work they've done to make this webinar possible. I'd like to introduce Dr. Carla Lester, who's going to talk about the CME credits associated with this webinar, and we'll give you the background of the Foster Healthy Weight and Youth model. Dr. Lester is a pediatrician here in Lincoln. The third and nonprofit organization called the Mission is to prevent and reduce childhood obesity by empowering Lincoln children and families to eat healthy and be active. Dr. Lester also developed the Animated Childhood Obesity Prevention Project. Dr. Lester? Thank you, Tammy. Thank you, all of you, for joining us, and thank you especially to Dr. McBride for a talk that is very needed at this time. And today's webinar is titled Surgical Treatment of Obesity for Children and Adolescents. And our speaker is Dr. Corey McBride. Dr. McBride is the Director of Bariatric Surgery at the Nebraska Medical Center and is also Chief of Staff of the Medical Center and is Associate Professor of Surgery at UNMC as well. I'm going to go through some business here, reminding you about CME credit and also review Foster Healthy Weight and use clinical resources that are available and have existed to physicians across the state. The Creighton University School of Medicine does provide enduring material activities for a maximum of 1 AMA Category 1 credit. It has been approved through the AMA, the Nurses Association, and the Commission on Dietetic Registration. A detailed information sheet containing this information accompanied this webinar registration and can be found also on the Creighton CME website. The Creighton University School of Medicine is accredited by the Accreditation Council for Continuing Medical Education to provide medical education for physicians. After the webinar, actually probably tomorrow, you'll be sent a link to the post-test and evaluation via email. And you may also visit cme.creighton.edu for more information. This activity has been planned and implemented in accordance with the essential areas and policies of the Accreditation Council for Continuing Medical Education through joint sponsorship of Creighton University School of Medicine, Nebraska Medical Association, Teach a Kid to Fish, and Nebraska Department of Health and Human Services. And I just always want to remind you that neither the planning committee or the speaker for the webinar, for any of the webinar series, have any conflicts of interest or disclosures in maybe such. And now we'll talk about Foster Healthy Weight and Youth, which is Nebraska's clinical childhood obesity model. The clinical resources have been disseminated and continue to be disseminated to physicians across the state. It's a comprehensive model with a toolkit, pocket reference algorithm, 3 CME training video, which outlines the steps in assessment, prevention, and treatment in the primary care setting. There are also consistent messaging, patient brochures, and posters to resource your office with. All of the resources are free and available through the Nebraska Medical Association's COPP website. And with that, I'm going to go ahead and hand the talk over to Dr. McBride, and thank you for joining us today.
Thank you very much. Do I have control of the slides yet?
One moment.
Okay. Well, thank you for allowing me to talk to you today. Clearly, prevention is the way to go with obesity, and I don't think anyone in the surgical or as a surgeon and as your colleagues, if we can prevent obesity, that is the way to go. However, occasionally it appears that it is appropriate to consider surgical means for these primarily adolescents. There are a few centers around the country that will operate on children, but very few. So it says I can take control, so let's see. No. My monitor still says that you have control of the slides.
Give it a try now.
Nope. So, okay, well, I'll ask you to do it then. So the objectives today are to look at the problem of obesity, especially in adolescents, look at some of the most popular surgical options for weight loss, and try to give you an understanding of the risks and benefits. And there's a limited amount of published data on surgery in adolescents, but I'll try to review that for you. Next slide, please. Actually, some of these intro slides I'm sure have been covered by other speakers in your webinar series. We all know obesity is a serious problem in the United States. Over a third of Americans are considered overweight and a third are obese. And the number of deaths attributable to obesity is rising every year. In fact, in 2012, for the first time, obesity is expected to overtake smoking as the #1 cause of death in the United States, or attributable death in the United States. Next slide, please. Everyone should have at this point seen a BMI chart like this, with the height across the top, the weight down the side, and typically BMIs under 25 are considered normal, 25 to 30 are obese, 30 to 35 are severely obese, and greater than 40 is categorized as morbidly obese. Within the surgical literature, though, we understand that the risks continue to rise as weight rises. So for every 10 the BMI is over 40, the risks of the surgery themselves go up, and it has to be part of our risk-benefit conversation with patients. Next slide, please. The list of obesity-related health problems is long, and it's not isolated to adults, but these are the ones we typically see in adults. Next slide, please. The NIH has had several consensus conferences over the years, and in 1991 they published their first guidelines that included surgery. They were very clear in those guidelines that these were for adult, well-educated, well-informed patients. But they did feel there was a benefit to considering surgery for BMIs over 40, even if they did not have any health problems yet, or a BMI over 35 if they had a high-risk health problem that was linked to weight. Next slide, please. In 2004, the NIH updated their position. They did not change the criteria for adults at all. They simply added a paragraph where they recommended that adolescents should be referred to specialized centers with multidisciplinary teams that were dedicated to long-term follow-up, participation in research in a central database, and then all of the specialties necessary to take care of the unique needs of children and adults and their families needed to be part of the multidisciplinary team. Next slide. There are a few other indications, not necessarily that meet that are with the NIH standards. For example, the lap band is now FDA indicated for patients with a BMI of 30 to 35 with medical comorbidities. However, very few insurance companies have changed their criteria to match that of the FDA. I realize I didn't put in a disclosure slide at the beginning. I have no financial conflicts, but I will point out to you that banding surgeries are not currently FDA approved for under 18. And as a result, Nebraska Medicaid will not cover them since they are not FDA approved. As a note, practicing in Omaha near Offutt, TRICARE actually does not use BMI criteria as part of their decision making. They go with pounds overweight or percent over ideal body weight. But these are the general kind of indications that we're working with regardless of age. Next slide, please. Beyond that, the additional requirements vary by the patient and they vary by the insurance company. But the general trend is that the insurance companies want to see that the patients were obese for at least 5 years. They can't be smoking, they can't be substance abusers, and they have to be in stable mental and physical health with the support of a mental health provider if they need one, and certainly support of their primary care physician to ensure that they are stable enough for surgery. Next slide, please. Most insurance companies do require that patients have tried diet and exercise type options before they will approve them. However, there's actually no peer-to-peer literature that suggests success with previous diets predicts success with surgery. Having said that, it's part of almost every insurance policy's criteria. Some are liberal enough that patients can self-report. They've tried Weight Watchers, they've tried Jenny Craig, they've tried low-calorie diets. Others are stricter and want to see evidence of either a physician or a mid-level or dietitian supervision in the diet with regularly scheduled weigh-ins and counseling, and most of them want to see at least a 3 to 6 month effort in the last few years. And I've listed some of the ones that are particularly strict in our area. For example, Wellmark Blue Cross of Iowa has very strict guidelines that the weigh-ins can't be any closer than 28 days, can't be any further than 35 days, or the patient automatically gets bopped out of line and has to go back and start their 6 months over again. So they vary in how strict they are, but every insurance company seems to have something written in their rules. Next slide, please. Now, as far as adolescents go, there are sort of two different criteria that seem to be used by most people who are considering surgical intervention. As you all know, obesity in children and adolescents is typically defined as a BMI greater than the 95th percentile for age. In general, though, since we're dealing, and that's the programs that will operate on children down to age 9, typically use this criteria. To my knowledge, at the Nebraska Medical Center, we're the only program that will do adolescents in the state. And in general, most of the adolescents we are looking at have already reached their final adult height, or within an inch or two of their final adult height, have already gone through the majority of their puberty, and so we find that using IDELT criteria for the most part works as far as calculating the BMI and evaluating whether or not they would qualify for surgery. Next slide, please. Again, I don't need to tell anyone listening about the problem we have with adolescents who are morbidly obese. According to the NEHAS data, about 18% of our adolescents are currently obese, with 1 to 2% of them being morbidly obese. And if you have childhood obesity, your risk of having adult obesity is greater than 80%, and it's even higher if one of the parents are obese. And it's not just about the weight. We are starting to see all of the health problems that we had typically associated with adult obesity now in our adolescent population, including diabetes, high blood pressure, hypertension, sleep apnea, all of the dyslipidemias, joint pain, etc. Next slide, please. If you compare the NEHAS data from the 88 to 94 time frame to the 2007-2008, which is the most recent that we have, you see that the percent of both boys and girls who are obese has gone up across the board, and specifically in certain ethnic minorities, with a 30% risk of being obese in our non-Hispanic Black female population. And that's a huge number of our children. Next slide, please. In 2003, SAGES, which is the major adult laparoscopic surgical society, and IPEG, which is the major international pediatric laparoscopic surgical society, had a joint session to discuss surgical treatment in adolescents. And while this was not a consensus conference, by the end of the day, most of the speakers had come up with an idea of what was necessary to consider surgery. Everyone was in agreement that the patient, meaning the adolescent, must be the driving force. This can't be mom's idea or grandma's idea or even the primary care doctor's idea. If the teenager or adolescent is not ready to make the dietary changes and the exercise changes necessary to succeed, this is not a good idea. If they are not committed to changing what they eat and how they eat, it's not a good idea. And different programs have different ways of trying to get at this idea. Some teenagers are very verbal and communicative, and I can sit down and have a conversation with them, and I get a clear understanding of how much they understand about surgery. There are others who will not say 3 words during an entire encounter, and I've asked them to sit down and write me a letter and explain to me why they think this is important, their understanding of the risks and their understanding of the benefits, because I really want to understand that they're the ones driving this. Now, in 2003, SAGES and IPEG and most of the speakers who were there from the major programs around the country recommended that we really should be a little stricter with adolescents than we are with adults. And they felt that the BMI criteria should be bumped up, that we really shouldn't be thinking about surgery until there's a BMI greater than 40 with comorbidities or greater than 50 without comorbidities. However, since that time, they've attempted to have multiple consensus conferences, and nobody has come up with a statement regarding adolescents that is any different than that of the NIH criteria of BMI of greater than 35 or BMI greater than 40. Most programs who will consider adolescents do want to see evidence of weight-related comorbidities, and they do want to see that the patients have at least begun and are really towards the end of puberty. Next slide, please. Now, there are only 2 studies that actually kind of tell us how many of these operations have been done. There was one study that was published in 2007 that looked at the nationwide inpatient sample, and they found that in the early years, 96 to about 2000, about 200 to 250 cases were being done each year. Most of these were open gastric bypasses, and there wasn't a lot of change. However, in 2003, there were 771 cases, and that corresponds to the introduction of laparoscopic gastric bypass and the FDA approval of the lap band, even though it's not FDA approved for this patient population. Despite that, this is less than 1% of all the bariatric procedures being performed in this country, and in this particular year, in this 771 cases, there were no in-hospital deaths in adolescents, which was different than the adults in the corresponding time period. Next slide, please. The other published data regarding adolescent utilization was published a year later in 2008. They managed to identify 282 patients, and they were really looking more at resource utilization. These 282 patients had the actual operations were done at over 100 different hospitals, and the majority of the hospitals that had operated on adolescents did fewer than 4 cases a year. The majority of these operations were done at adult centers that do greater than 200 adult cases a year. They just don't do very many adolescents. There was an approximately 6% complication rate, and again, no in-hospital mortality. Next slide. So the next thing I'm going to do is review some of the commonly done bariatric surgery procedures in the United States, and we'll kind of go over each procedure, look at the risks and benefits, and I'll present the data that I've been able to find regarding adolescents. Next slide, please. When anyone thinks about bariatric surgery, there are multiple operations, and really they fall along a spectrum. At one end of the spectrum, which is represented on the far left of the screen, are the purely restrictive operations. These are the ones that limit the quantity of food that the patient is going to eat. But once it makes it past the restriction, the food is digested normally, the vitamins are absorbed normally. Examples of this type of operation include the laparoscopic adjustable gastric bands, and there are 2 brands currently available in the United States, and the laparoscopic sleeve gastrectomy. At the opposite end of the spectrum are the malabsorptive procedures, and these are the ones done on the small bowel that interfere with digestion so that the food is not digested normally, the calories are not absorbed, the transit times are faster, and the vitamins aren't absorbed. Now, there's actually no examples of malabsorptive procedures being done in the United States in 2011, and I'm not aware of any that have ever been done in adolescents, even historically. And then in between on the spectrum fall the combination procedures. And these are operations that have both a gastric component and a small bowel component. So they limit how much food the patient can eat, but they also bypass between 6 and 12 feet of intestine typically, and so not all of the calories are absorbed and not all of the vitamins are absorbed. As we go through these operations, I'm going to kind of go from most restrictive, and we'll cover the restrictive operations and then the combination procedures. But the other thing you'll notice as we're talking about it is as I present them, we're talking about lowest risk to highest risk. And so each operation carries a little more risk than the one before it. Next slide, please. So starting with the laparoscopic adjustable gastric bands. There are 2 of these currently on the market, the lap band and the realize band. And from a pure product standpoint, they're almost identical. They are both made out of silastic. They are a band that is placed around the upper part of the stomach. There is a balloon on the inner surface of the band that I think you can best see on the picture of the lap band. There's tubing that leaves the band, and then there's a small reservoir that sits under the skin. And so in clinic, by accessing that reservoir with a needle, we can add fluid to the band, tighten up the balloon, and make the operation more restrictive. And I'll say, hopefully for the last time, neither of these is currently FDA approved for children under 18. There are clinical trials being done for both of them, but we probably won't have the data for another year to a year and a half before it can go to the FDA to consider the FDA indication. In general, they're very similar as far as how you put them in, what kind of follow-up you need, how you do adjustments, and the complications. So I'll really lump these 2 together. Next slide, please. So the band, as this cartoon shows, is around the upper part of the stomach, and then the stomach is sewn to itself around the band to try to prevent the band from moving. This is the safest operation I can do on anyone considering weight loss surgery, but it is also the easiest one to cheat with because liquid calories will go down just fine. So the patients have to be very committed to changing their diet to primarily solid, healthy food. Fish, grilled chicken breasts, steamed vegetables, and avoiding liquid calories and sweets. Otherwise, they can absolutely sabotage this operation. As you can see on the slide, the average weight loss is anywhere from about 30 to 70% of what people need to lose. And the reason that is such a large gap has to do with how much people cheat. I have patients who are unfortunately heavier today than they are the day they got their band because they've really cheated from day one, and I have patients that are all the way down to their ideal body weight because they've took the tool the way it was designed and intended and used the tool. As I mentioned, this is definitely the safest surgical procedure in all age groups in anyone considering surgery. It's a slow, steady weight loss. It takes about 3 years to achieve everything that you're going to lose. There's also no end to it, though. I have had patients that work with their band well for a year or 2, and then they decide to have a baby, or they decide it's not the right time for them to really be working on it, and they don't come in for the follow-up they need. However, a year or 2 later, if their weight starts to creep up, they can come back in. We can do another adjustment and help get them on track. So this really has the potential to be a tool that you can use over the years to get you what you need. There's no malabsorption, so once the food makes it past the band, it's digested normally. It is a reversible operation, but it is worth noting that if we take the band out and we go to a different bariatric surgery, that second surgery carries a lot more risk than a first-time surgery because there are changes to the stomach and thickening and scarring that increase the risk of the next operation. Next slide, please. This is a very short operation. It can take less than an hour. Most programs send patients home the day of surgery or day 1. I have operated on people on Friday and they return to work or school on Monday. So the initial operation is very low risk and has a very short recovery associated with it. However, it does require more follow-up than any of the other operations. Patients have to come in, they have to get their band adjusted. The more often they come in, the better the weight loss. In an adult population, the average weight loss in the United States, now 5 to 10 years out from when it was first introduced, is somewhere around 60% of excess body weight loss, and it really takes about 3 years to get there. But with this weight loss comes a dramatic improvement in health. Diabetes is resolved about 48% of the time and improved about 80% of the time. High blood pressure resolution is about 42%. As well as this is an excellent reflux operation. It almost eliminates sleep apnea in our larger patients, and in adults with chronic sores or venous stasis, they improve or resolve as well. Next slide, please. This is a little cartoon of what an adjustment looks like. A Huber needle is placed into the reservoir, fluids injected, and the result is that the band fills up and tightens. And that tightening around the stomach does a couple of things. It helps patients not be as hungry, and then when they do eat, a small amount of food will help them feel full. But as I mentioned, liquid calories will go right past this if they don't really change what they're eating. Next slide. But there is a device in there. The lap band and the Realize band share the same complications, and as far as we can tell, the same complication rates. It is a piece of plastic. It can slide up or down like the top picture shows. In that one, the band has slid down, so there's just too much stomach above the band, and so patients can eat a lot more, and they're not going to lose weight as we would hope. The middle picture is a picture of an erosion, meaning a band that was placed on the outside of the stomach has now eroded to the inside, and we're seeing it on upper endoscopy. When this happens again, patients lose all sense of restriction, and they really can eat whatever they want. Plus, there's now an infection risk associated with the GI flora infecting the band and causing infection. And then if the band gets over-tightened or if food gets caught, you can get obstruction and esophageal dilatation. The current statistics, when you clump all of the studies together, are that about 10% of patients are either going to need their band repositioned or a portion of it replaced, or it actually removed and converted to another bariatric operation. But the range is very high, and there are some studies that are showing as high as 30 to 40% removal or revision rate as we go out with time. Next slide, please. As far as adolescents, there are only a few very small studies. This one that I have on the screen now came out of Australia. It was 20 patients. 5 of them had had relatives who'd already had banding surgery. They started out with BMIs of about 44, and with about 2-year follow-up and an average of 12 visits, so 6 a year, they got down to an average BMI of 30 with an excess body weight of 28%. Now, there were complications, but no deaths in this patient population. Next slide. The next operation I'm going to tell you about is the laparoscopic sleeve gastrectomy. This is also a restrictive operation. It is the only truly non-reversible surgery, because what we do is we take staplers and we staple from the bottom of the stomach to the top of the stomach, and we remove about 4/5 of the stomach. We remove all of the fundus and most of the antrum. Ghrelin seems to be produced in that part of the stomach, and ghrelin is the hormone that makes you hungry. So by taking out that part of the stomach, this operation actually works in 2 ways. First off, it's restrictive because that very small tube of stomach is all that's left, and it can only hold about 100 cc's at a time. But also, by removing the ghrelin-producing parts of the stomach, patients just aren't hungry for about 2 to 3 years. And it's much easier to learn new eating habits if you're not hungry all the time. This is definitely the new kid on the block. We really only have about 3 to 5 year data. A lot of insurance companies will not cover it because we don't have long-term data yet. But really, every couple of months, we've been having more and more insurance companies that are acknowledging that this is a good operation with good outcomes and an excellent safety profile. Currently, Nebraska Medicaid does not cover this. But we're always working with them trying to change their mind. Next slide, please. In the adult population, the excess body weight is between about 50 and 60%, and the early data is that the weight loss is as good as a gastric bypass, and the improvement in health is as good as a gastric bypass, but it's missing a lot of the risks of a bypass. There's no risk of internal hernias, there's no risk of dumping syndrome, there's fewer vitamin deficiencies, protein malnutrition. The actual surgical procedure is lower risk when it comes to leaks and DVTs and PEs and pneumonias and pulmonary complications. There's no foreign body like a band. There's no need for adjustment. So a lot of people are really suggesting this is a good idea for rural states like ours because it's really hard for patients to drive 2 and 3 hours once a month to make it to Omaha to get an adjustment, whereas this one does not require quite as much follow-up. Some of the follow-up can be done by the primary care provider closer to home, and so it's not as big a burden. The follow-up is not as big a burden. But if necessary, this operation can always be turned into a gastric bypass down the road. In fact, when we first started doing it, we conceived of it as an operation that when you were talking about someone who was 600 or 700 pounds, if we did this and helped them lose 200 pounds, then we could go back into a gastric bypass and we could help them lose another 200 to 300 pounds to get them down to where we needed to be in a staged fashion and most importantly a safe fashion. Next slide, please. As I mentioned, it does have risks, but all of these risks, while they are higher than a band, are lower than a laparoscopic or open gastric bypass. And they include leak, bleeding, nausea, vomiting, DVTs, PEs, wound problems. And the mortality rate is really not quite known. It is clear that it is between bands and bypasses, but it really varies depending on the patient size, their comorbidities, their health, and to some degree the experience of the surgeon. Next slide, please. There is no published data on the sleeve in adolescents, but I wanted to introduce you to a young man that I've now known for a couple of years who has given me permission to tell his story far and wide. This is Elliot. Elliot was diagnosed with leptin deficiency, or leptin resistance, at age 3. And as a result, he never felt full. He had never felt full a day in his life. He could eat Thanksgiving dinner 3 to 4 meals a day and never felt full the way the rest of us feel full. He first saw the endocrinologist at Children's Hospital at about age 13, and at that point he had a BMI of 46, he had high blood pressure and was on 2 medications, he had hyperlipidemia for which he was on 2 medications, and his weight was only getting worse. And up until that point he'd been able to play football and sports, but his weight had gotten to the point that he'd had an ankle injury, and now he couldn't even exercise or do any sports. I met him when he was age 16. His BMI had grown, he had gained 10 centimeters, but his weight had outpaced his height for growth, and his body mass index was now up to 57. When I first met him, his leptin levels were 152, and if you, the lab that we send to says normal is less than 12. It took 18 months to get him ready for surgery. He saw counselors, he saw dietitians. He's one of the teens who I had write me a letter because he was unable to really verbalize why he wanted to do this. It's worth mentioning both of his parents are BMIs of 23 and normal weight, as are all his siblings. But after 18 months, I really felt like he was ready. Now, his insurance company would not cover this, and in the end, his parents self-paid for this operation because they genuinely believed it was the only thing that would save their son's life. And so at age 17, he had a laparoscopic sleeve gastrectomy, and the day before surgery, the leptin level was 102. Next slide, please. This is Elliot a few months ago. Since 6 months out from surgery, his leptin levels have all been less than 10. He reports that he is not hungry and is able to stick to healthy, low-calorie diets. He is able to exercise and play sports again. He has lost almost 200 pounds. And when I saw him a few months ago at his 2-year follow-up, he was down to a BMI of 26. He's a junior in college. He's playing sports. He has a girlfriend. He has a job. And his life is completely different than I think most of us imagine it would have been if he'd stayed the size he was or had gotten healthier. His high blood pressure has resolved. His hyperlipidemia has resolved. He is off all of his medicines. He no longer sleeps with a CPAP. He's a healthy 20-year-old kid that when you look at him, you would never believe used to have a weight problem, even though he still wears baggy clothes. Next slide, please. The final operation I wanted to tell you about is the gastric bypass. Now, this can be done open or laparoscopic. This cartoon leaves out the fact that this part of the stomach we don't use for the gastric bypass is left in place, and that's one of the things that makes it different than the sleeve. The average patient loses about 65% of what they need to lose. It's a much tighter bell curve around that number because it is harder to cheat with this operation. It takes about a year to a year and a half to lose everything they're going to lose, but it definitely has a higher risk than any of the other operations I've told you about. The leak rate is about 2 to 3%, and with that can come the risk of peritonitis, sepsis, multi-organ failure. The PE-DVT rate is about 2%, and the mortality, depending on the literature you read, is about 0.2 to 1%. Again, depending on the patient's baseline health, their comorbidities, their size, and also where the surgeon is on the learning curve for laparoscopic. There are definitely long-term nutritional requirements, though, that again make this different than the other operations. Next slide, please. However, with this dramatic weight loss comes a dramatic improvement in health. 5-year data out of Northwestern University showed that 64 to 100% of diabetics either had improvement or resolution. Now, it definitely had a better resolution rate if they'd had diabetes less than 5 years. And so if we see teenagers who are already diabetic in their teens, we need to be intervening usually within about 5 years if we're going to have hope of impacting diabetes as a comorbidity. The hypertension rate goes away, obstructive sleep apnea goes away, dyslipidemia, they get off their meds. Non-alcoholic steatohepatitis improves in about 90% of people. And certainly at the Nebraska Medical Center, where we have a big liver transplant population, we've had a number of patients that seemed like they were on their way towards a liver transplant, that by helping them lose a dramatic amount of weight, we've managed to avoid the need for liver transplantation. Next slide, please. As I mentioned, this operation definitely has its risks, and it's important that everyone understand the risks. It's important that the patients understand the choices, and the adults who are influencing these teenagers understand their choices. And this is why it's important that they continue to have follow-up with their bariatric surgeon, because some of these complications are best and more safely diagnosed when it's an early diagnosis than when it's a late diagnosis. Next slide, please. There are the potential for nutritional complications. Anemia is by far the biggest nutritional complication. Typically it's iron deficiency anemia, but the B vitamins and folic acid can also play a role. There's a risk of calcium hypocalcemia and osteoporosis. The risk of true malnutrition, though, is very low. Most of these patients who start out with BMIs in the 35s to 40s still end up overweight with BMIs of the 25 to 30 range. Patients who start out with BMIs over 50 typically end up with BMIs in the 30s. So they're still overweight. They still may even be obese, but it's not about the weight as much as it is improvement of all of the comorbidities. Next slide, please. There are really only 2 good studies about gastric bypass in adolescents. This is an older study in which all the gastric bypasses were done open, and in fact there were actually some stomach staplings that go back to the late 70s. But of the 30 gastric bypass patients, you can see that they had the comorbidities that we also see in adults who are heavy. They did have complications both early and late. None of the late complications were related to surgery. One was a car accident, and one was related to a pneumonia and infection. And certainly because of the open, They had a higher incisional hernia rate than most other studies. Next slide, please. However, when you exclude, and there were 5 failures, people who regained all of their weight, usually because of a technical problem with the gastric bypass. If you exclude the 5 failures, you see that they had a dramatic weight loss and a dramatic improvement in their body mass index, and that they lost a significant amount of their excess body weight loss, and that those results were durable at 5 years, 10 years, 14 years. So this is not a quick fix. It's an operation that has long, durable results. Next slide, please. In addition to losing weight, the majority of the comorbidities resolved, and at the time of publication, 8 of them had gone on to marry and have children, 6 of them had completed college, and none had any evidence that their gastric bypass had impaired their additional physical maturity. Next slide. As far as the laparoscopic gastric bypass, again, there are really only small studies out there. This comes from a group in California. They had a heavier patient population to start, but with significant comorbidities, as you can see. Next slide, please. And at 1-year follow-up, they had lost weight that was the same as all of the adult published studies with 55-kilogram weight loss. There were some early complications, but they demonstrated the same weight loss, if not a little better than adults, and the same improvements in comorbidities that we see in the adult literature. Next slide, please. This is my cartoon of a little lady and all of the health problems that have been associated with improving health through surgery. Now, all of these benefits are related to how much weight patients lose. So if they have surgery but cheat and don't make the behavior changes and don't lose much weight, you would not expect to see these health improvements. But when they lose weight, there's a potential for a dramatic improvement in their health. And really, their weight is affecting just about every organ system in the body, and just about every one of them gets better. But the data that just really shocks me every time I look at it is down in the bottom left, and that's quality of life. If you look at SF-36 scores for obese Americans, they score worse than people with terminal cancer. And after surgery, they score the same as the normal adult population. And the mortality numbers are staggering, with an 89% reduction in mortality when you compare patients who had surgery and patients who didn't have surgery. And all of those studies that point to this mortality are studies where the only difference between the patient groups was whether their insurance said yes or whether their insurance said no. Next slide, please. As far as long-term care, next slide, please. All of these patients need to see their bariatric surgeon regularly. It varies a little bit depending on which operation they have, but it's important that they get the counseling to be successful in the long term, to keep the weight off, to continue exercising. It's important that if there are any complications, they be identified early, and the bariatric surgeon is typically the person best suited to do that type of follow-up. It's very important that their primary care physician be involved, monitor their blood sugars, wean their medicines, their antihypertensives. If they've got sleep apnea, get a follow-up sleep study to see if we can get rid of the CPAP machine. And if they see a mental health professional, it's very important that the therapist be involved and that they continue to see them as they always have. I'm very honest with patients. You know, most heavy patients think that their weight is the cause of their depression. And if they could just lose weight, they're sure their depression would go away. But this operation has nothing to do with the chemical changes in the brain. And it's very important that they not go to cold turkey on their psych meds, that they continue to get the follow-up that they need. And we stress that over and over with patients. Next slide, please. I do recommend vitamin supplementation for the first 6 months for band patients while they're rapidly losing weight, also sleeve patients. But in the long term, band patients do not tend to need even a multivitamin. Gastric bypass patients, on the other hand, need a multivitamin, calcium, vitamin D for life. Women need extra iron until they stop menstruating, and they require follow-up of all of these vitamins. And about 10% of patients, even if they take this vitamin regimen, will need some tweaking to it. They need more folate, or they need more B12, and that's what the lab work and the follow-up with the bariatric surgeon helps identify. Next slide, please. Now, there is an exciting project that's being done right now called the Teen Labs Study, and they're enrolling about 200 patients at 4 major pediatric medical centers that also do bariatric surgery. They're going to follow these adolescents for weight and complications and comorbidities. I have verbal communication that they've actually stopped enrolling, and then they expanded their charter, and they're just going to continue to get as many children as they can in this 5-year period. And so hopefully we will have the data we finally need after that to really have a good understanding of the safety profile and the weight loss and the complications and comorbidities for adolescents. Next slide, please. Now, the Journal of Pediatrics just this month released a supplement in which, next slide please, they attempted to identify what a adolescent bariatric surgery program should be. And honestly, this list looks like the same as what a bariatric program from adults should be. You have to have the institutional commitment. You have to have communication with the primary care doctor. You have to have the experience in operating on adolescents in order to learn these procedures. They do recommend a 6-month mandatory weight loss program, which, again, most insurance companies already require. Next slide, please. They want a multidisciplinary team, the specialized equipment necessary to take care of these heavier patients, clinical pathways, standardized care, commitment to follow-up. Next slide, please. Sorry, that's out of order. And this is a list of really the practitioners that they think should be part of that multi-D team. You need a surgeon and a surgical director, but you also need a medical director who coordinates their care, mid-level providers, psychologists, dietitians, social workers, exercise therapists, and certainly on the inpatient side, consultative services to all the appropriate specialists, including age-appropriate intensivists if they do end up in the ICU. Next slide, please. And then finally, support groups and a transition care plan so that they get the lifetime care once they're no longer adolescents. And most programs do that by pairing their adolescent program with the adult program so that they can transition to the support all of our adults get for long-term care. Next slide, please. So in summary, surgery is an option for adolescent patients with a BMI over 35 who have comorbidities and who are very close to reaching their adult height or have finished puberty. Now, the different operations clearly have different risk-benefit profiles. They have slightly different dietary needs. They have different vitamin needs. And so it's a very individualized choice about what is the best operation for each patient. I completely agree with the pediatrics consensus that these patients should be referred to high-volume centers that are committed to the idea that adolescents are different than adults and make adjustments to their multi-D team to ensure that we have all of the specialists necessary for adolescents if you're going to care for them. At this point, I would be happy to answer any questions.
Thank you, Dr. McBride. I'm going to open the webinar up to any questions you might have. You can type the questions under the chat or questions section on the right of your screen, or if you prefer to ask in person on the phone, you can push the little raise your hand button and we will unmute your line. We'll take just a couple minutes here and let people put their questions in. Dr. McBride, this is Dr. Lester. Thank you for your talk. It's extremely helpful. What I'm wondering is, what is the system that's in place for children in Nebraska as far as, I know there's a clinic, Children's Heroes Clinic, but is there something like, here in Lincoln we have gaps in intervention services, so to have a child who would perhaps qualify for bariatric surgery but would need to have that counseling and the dietitian and multidisciplinary clinic intervention trial before to prove that it's a little bit difficult. I don't know if you're noticing that.
There is not a statewide program certainly that does this, and unfortunately the program at Children's Hospital that you mentioned with Dr. Franken is probably the one I utilize the most. The majority of the adolescents I've operated on have gone through his program, and he's the one who refers them on to me. Or they get to me through some other specialist at Children's Hospital, but he's been involved in their care. Because it is difficult. I mean, the first few adolescents before that program really existed that came to me, you know, it was very hard to find a child psychologist who was willing to look at them and evaluate them because they just didn't have the experience and the background to deal with it. And the adult psychologists didn't want to do it because they felt like these are adolescents and they were, I think, concerned they'd miss things. And so, and unfortunately, even at the Nebraska Medical Center, we don't have a program that can necessarily do these things. Now we're actually working to it, and I'm hoping strategic planning will approve it next month, in which case we will be aiming towards a program that has both a surgical and a medical arm and can meet all of the needs of our patients in sort of one location. But other than the children's program and our relationship with the children's program, I'm not aware of any others.
Okay.
I mean, there are bariatric surgeons in Lincoln, but I don't believe they operate on adolescents. In fact, I think they usually refer them to me.
Mm-hmm. Dr. McBride, we had a question come in. Have you ever worked with adolescents with developmental disabilities or mental illness, and is surgery ever recommended for those with disabilities if they fit other criteria?
Right. That's an excellent question. In general, the problem with adolescents or adults with impairment to their understanding and intelligence is in order for any of these operations to work, the patient really has to change what they eat and how they eat. And so in general, limited intelligence is a contraindication. There are centers that have done some of these operations, for example, on kids with Prader-Willi, and they uniformly fail. Now, I don't know if anyone has ever done a sleeve on a Prader-Willi, and because of its ability to kill the appetite, that may be an option, but it'd be one we'd have to have really long discussions about. But in general, intellectual limitations tend to be a problem. And I have certainly evaluated both adolescents and young adults that, for example, have Down syndrome or something else that's impairing their intelligence. And I think their parents have the best intentions in the world by bringing them in. And they say, well, you know, I'll control what they eat. I'll understand the diet and I'll make them eat what they need to eat. And it's kind of like, well, if you could do that, you would already be doing that. And so, in general, that's a contraindication to surgery. Now, physical limitations are not. All of these operations will succeed better in someone who can exercise versus someone who cannot. But we have certainly done people with physical limitations, multiple sclerosis, Parkinson's disease, paraplegia and quadriplegia as a result of accidents or birth anomalies. And while they may not lose quite as many pounds as they would have, they can lose a significant amount of weight. Several of our paraplegics, you know, their only goal was to be able to go back to independent transfers, and they meet that goal easily, and the rest of their health improves as well.
I think we have one more here. Are you recommending leptin levels when you have like a severely obese child?
I think it's something, I think that's why having a pediatric endocrinologist involved in their care is important. I mean, I look back on Elliot's workup by the endocrinologist, and you know, they did tests that are not part of our routine testing in adults. You know, most adults, you make sure they don't have diabetes, you make sure they don't have a thyroid problem, you correct those issues, and that's about the extent of the endocrinologic workup that most adults get before we consider surgery. But clearly in children, especially when they've been obese since 2 and 3 years of age, like Elliot was, there's something else there. And I really depend on my pediatric endocrinology colleagues to help point me in the right direction and make sure we haven't missed something on these kids before we consider surgery. Unfortunately, there are no commercial labs that can tell us about ghrelin levels. You can't send a lab test off for a ghrelin to figure out if that is abnormal, to figure out if it is if it's related to hunger. But you can get commercial leptin levels.
Okay, I think we're approaching the 1 o'clock hour here, so we'll go ahead and wrap this up. Dr. McBride, thank you again for a wonderful presentation and for fitting us into your schedule. You know you're busy. So,
well, I appreciate the opportunity. Thank you again.
For those who were part of the webinar today, you're eligible for the 1 hour of continuing education. You will receive an email tomorrow that will have a link to the post-test and evaluation so that you can take those. And the encore presentation will be available on the Nebraska Medical Association Childhood Obesity Prevention Project website. You can see the website there, med.org/VOPP.ASPX, and it should be available within a couple of weeks of this live presentation. And if you have any other questions, feel free to contact us as well. The Foster Healthy Weight and Youth resources are available on the website as well, or you can get copies from Holly here at the state. And with that, I think we'll go ahead and close things for today. Thank you all for taking the time to be a part of the webinar, and we look forward to another one in November. Thank you.